How to read CT scan. Brain images clinical. How to read a head CT. Or how I learned to stop worrying and love computed tomography. Head CT has assumed a critical role in the daily practice of emergency medicine for evaluating intracranial emergencies. For example, trauma, stroke, SAH, ICH. Most practitioners have limited experience with interpretation. In many situations, the emergency physician must initially interpret and act on the CT without specialist assistance. Head CT. Most EM training programs have no formalized training process to meet this need. Many emergency physicians are uncomfortable interpreting CTs. Studies have shown that EPs have a significant miss rate on cranial CT interpretation. Head CT. In medical school, we are taught a systematic technique to interpret ECGs, rate, rhythm, axis, etc., so that all aspects are reviewed, and no findings are missed. Head CT. The intent of this session is to introduce a similar systematic method of cranial CT interpretation, based on the mnemonic. Head CT. Blood can be very bad. Blood can be very bad. Blood. Cisterns. Brain. Ventricles. Bone. Blood can be very bad. Blood. Cisterns. Brain. Ventricles. Bone. Blood can be very bad. Blood. Cisterns. Brain. Ventricles. Bone. Blood can be very bad. Blood. Cisterns. Brain. Ventricles. Bone. Blood can be very bad. Blood. Cisterns. Brain. Ventricles. Bone. CT scan basics. Introduced in 1974 by Sir Geoffrey Hounsfield. The original Cyretum circa 1974. CT scan basics. A CT image is a computer-generated picture based on multiple X-ray exposures taken around the periphery of the subject. X-rays are passed through the subject, and a scanning device measures the transmitted radiation. The denser the object, the more the beam is attenuated, and hence fewer X-rays make it to the sensor. CT scan basics. The denser the object, the whiter it is on CT. Bone is most dense equals plus 1000 Hounsfield U. Air is the least dense equals 1000 H Hounsfield U. CT scan basics. Windowing. Focuses the spectrum of grayscale used on a particular image. Two-sheet head CT. Posterior fossa. Brainstem. Cerebellum. Skull base. Clinoids. Petrosal bone. Sphenoid bone. Sella turcica. Sinuses. CT scan. CT scan. Sagittal view. Cisterns. CT scan. Brainstem lateral view. Second key level sagittal view. Second key level. Cystons at cerebral peduncles level. CT scan. Suprasellar cyston. CT scan. Third key level sagittal view. Cystons at high midbrain level. CT scan. Ventricles. CSF production. Produced in choroid plexus in the lateral ventricles foramen of Monroe I. Ventricle aqueduct of Sylvius IVTH ventricle Lushka / Migandi. 0.5-1 cc / min. Adult CSF volume is approximate 150 ccs. Adult CSF production is approximate 500 to 700 ccs per day. CT scans. 36. Trauma pictures. Pathology. B is for blood. First decision, is blood present? Second decision, if so, where is it? Third decision, if so, what effect is it having? B is for blood. Blood becomes hypodense at approximately 2 weeks. Blood becomes isodense at approximately 1 week. Acute blood is bright white on CT, once it clots. B is for blood. Blood becomes hypodense at approximately 2 weeks. Blood becomes isodense at approximately 1 week. Acute blood is bright white on CT, once it clots. B is for blood. Blood becomes hypodense at approximately 2 weeks. Blood becomes isodense at approximately 1 week. Epidural hematoma. Lens-shaped. Does not cross sutures. Classically described with injury to middle meningeal artery. Low mortality if treated prior to unconsciousness. 20%. Image. CT scan. CT scans. Subdural hematoma. Typically falx or sickle-shaped. Crosses sutures, but does not cross midline. Acute subdural is a marker for severe head injury. Mortality approaches 80%. Chronic subdural usually slow venous bleed and well tolerated. Hemorrhage. Subarachnoid hemorrhage. Blood in the cistern's forward/cortical gyral surface. Aneurysms responsible for 75 to 80% of SAH. AVMs responsible for 4 to 5%. Vasculitis accounts for small proportion, 1%. No cause is found in 10 to 15%. 20% will have associated acute hydrocephalus. CT scan sensitivity for SAH. 98 to 99% at 0 to 12 hours. 90 to 95% at 24 hours. 80% at 3 days. 50% at 1 week. 30% at 2 weeks. Depends on generation of scanner and who is reading scan. CT scan. 52. Image. CT scan. 53. Intraventricular / intraparenchymal hemorrhage. 54. CT scan. 55. C is for cisterns. 4 key cisterns. Circummesencephalic. Suprasellar. Quadrigeminal. Sylvian. Cisterns. 2 key questions to answer regarding cisterns. Is there blood? Are the cisterns open? 58. '59. 60. B is for brain. Blood can be very bad. 62. Tumor. 63. Atrophy. 64. Abscess. 65. Hemorrhagic contusion. 66. 68. Mass effect. 69. Stroke. 70. 71. '72. Intracranial air. Intracranial air. 74. Intracranial air. 75. V is for ventricles. Blood can be very bad. 77. 78. Ex vacuo phenomenon. 79. 80. 81. Bone. 82. 83. 84. 85. 86. Three Stooges. Blood can be very bad. If no blood is seen, all systems are present and open. The brain is symmetric with normal gray-white differentiation. The ventricles are symmetric without dilation, and there is no fracture. Then there is no emergent diagnosis from the CT scan. The CT scanner system plays a very important role in clinical diagnostics of brain, abdomen and whole body of human. The advanced scanners are imaging the cardiac system very efficiently. Thank you.